Hello, how's everybody today? Good? All right. This room is so big for the number of people that we have today. But anyway, welcome, and welcome also the people that are going to watch this later on, this lecture. So anyway, first of all, I would like to thank Dr. O'Gorman for inviting me to talk about what I do and what I believe in this area of vulnerable populations and health disparities. And you're fortunate to have him as instructor. And this is not a love fest. It is really. He's done a great job, and he's very generous with his time to UIS for many, many years. So again, I'm very glad to be here. Anyway, my lecture is called Vulnerable Population and Health Disparities, What Business Doesn't Get, or at least I didn't. Okay, and I'm going to tell you how I got where I am today. It took me a long time, and I'm so glad that you are going to start working with already a knowledge on this area. For me, it's completely new, or fairly recent. So anyway, what I'm going to talk about today, a little bit about my trajectory, how I got here, then a little bit about my interest, just an example of a project. We can talk more about that, and what I would like you to challenge with, so I leave you with an idea of what's next. So anyway, just as Professor O'Gorman was mentioning, this is part of my professional business career. As you can see, I mostly work in business marketing. I have a BA in marketing and an MBA, traditional business stuff, from Mexico. So right here in Monterrey, that's where I was. Then I went to Vancouver, Canada to study filmmaking. And when people ask me why I went to Canada to study filmmaking, my answer is, why not? There's no particular reason. I just wanted to do something completely different. So I did that for some time. And years later, I finished a PhD in advertising. So again, none of these healthcare related, so to speak, marginally. I'll talk more about that later. When I finished my PhD, before I finished my PhD, I worked mostly in market research and account management in ad agencies. And these positions were mostly on companies that I created. I don't like to have a boss. I hate to have a boss. I like academia because you are very free to do whatever you want, up to a point. As long as you teach well, as long as you do your research, you are very independent. And I love that, and I loved doing that when I had my own business. And after that, after finishing my PhD, I moved to the University of Florida to be assistant professor of advertising. And now I'm here in UIS in business administration, and I teach marketing courses. So you can see from here, there's not a lot on healthcare. However, what I've done for many years, since I started probably, or even in the PhD program, I do believe in doing interdisciplinary research. Interdisciplinary means getting together with people from other disciplines, from other areas of knowledge, and working on solving big problems. Because if I was just interested in a small thing, I could do it by myself. But when you are trying to solve major problems or tackle major research ideas, then it's a good idea to work with others. So anyway, for example, I have some research done, published, on hurricane-related messages, where basically, and for tourists in particular, because we believe that in some ways, tourists are vulnerable populations. Because you think about it, when you are with your family in Tampa, Florida, or Miami, and you've never been close to a hurricane, what do you do in case of a hurricane? What kind of how do you respond to messages? So in order to understand this, we had people from geography department, engineering, because we needed to study the traffic flows as well, from tourism, and social psychology. So my area was mostly the persuasive area and processing of data. So I was closer to social psychology in that case. Another project that I'm working on right now, that is also interdisciplinary. We're trying to see how people react after they see an anti-vaccination message online. And we believe that there are certain characteristics of the person, and when they got their vaccination, that helps them deal with negative information available online. So to do this, I have people from public health, communication, and healthcare management. So as you can see, this is pretty much what I've been doing for quite a bit of time. I get together with a lot of people working on problems, and some of them are already like this one, the last one. It was more about health promotion, okay? Which health promotion is basically how to motivate people to change behaviors, how to stop them from smoking, how to make them or help them understand the importance of getting vaccinations, so on and so forth. When I was here at UIS, I arrived to UIS in 2009, and I think that was 2010, 12, probably 12. I stumbled upon with the work of SIU, the School of Medicine, that is not too far away from here in Springfield. And here I met with, at SIU, met with Tracy Smith. She works at SIU, and she's basically in charge of putting together projects where we try to figure out how to help vulnerable populations in the Central Illinois area. So this kind of stuff that I have worked with her, one is called health literacy. Are you familiar with the term health literacy? Have you talked about it in class?
We haven't talked about that.
Okay, so for example, we had, in this project what we did, we had workshops where we taught healthcare providers about health literacy. What health literacy is, in very simple terms, is the ability of a patient or anybody to read some medical information and able to make a decision with that information. Okay, so we're very fortunate to have, we have higher education experience. We're able to read fairly complicated materials. A large majority of people that are involved in healthcare, and I mean patients and so on and so forth, they don't have the same ability than you and I to analyze that information. So what happens when someone that has low health literacy, they read a document and they don't understand it. They say, I just understand certain words, but not the whole thing, and I need to do something about it. It's how to take care of my wound while it's healing. How do I take this medication? So what we did was basically we just went to talk to healthcare professionals to say, hey, what kind of materials do you have? Can we help you make them more easier to understand? So that's some of the stuff that I have done with Dr. Smith. Other stuff that I work with SIU is hotspotting. I'm going to talk about that in a second. And the other is the InnoSpark community, which I also will mention more about it. And all of these projects are really fun to do, and I'll talk more about it. So anyway, in my work with SIU Med, I realized that, and again, that's for me was quite eye-opening. A lot of the stuff that I was teaching, doing research, and even my service was based on the idea of people like me, and maybe people like you, who we have enough resources to go to our doctors, we have enough capacity to understand medical information, that we have options through our insurance, that we have insurance, as simple as that. But there's a lot of people out there that do not have that. And we take that for granted, okay? So that for me, that was really revealing, and that happened, again, probably 3-4 years ago. I'm telling you the truth. I've been in this business for almost 20 years. Oh my gosh, yeah. Almost 20 years, and on those 20 years, for 16, I was like, whatever. People are people, they're gonna change their minds or not, or this or that. And then I realized, oh my gosh, this is serious. There's a lot of people that have other situations in life, and there's a big gap out of there. So anyway, probably have you talked about what a vulnerable population is? Have you mentioned a little bit? Yeah, so basically, just so we can have a certain definition, probably your definition is better than this, but basically is individuals that have issues with homelessness, HIV, poverty, even the people that live in rural areas, that they have limitations. And an example that is not here, but something that we see over and over again, is that there's so much trauma in these populations, where people were abused when they were young, where they have suffered violence from other people. All of those are examples of they are vulnerable populations. For them it's hard to access care. Again, probably you talk about disparities as well. So basically, difference of well-being or healthcare outcomes among different populations. Let me see. Hopefully this will. Let me see if I can make it work. Oh, there you go. Have you seen this website, the healthcare report for Illinois?
We have not.
Okay, so this one is just it's a very broad picture of what's going on all over the state, and it has some issues, but still is quite interesting. So it has all kinds of metrics about different illnesses as well as behavioral health of certain issues. Let's look, for example, at diabetes. So you can see the ones that are darker are places where there's more chances of finding people with diabetes. And do you see any pattern of where, and the darker the red, the worse the situation is there? Do you see any pattern on these counties, and even the ones that are like in this color? Anything? No? In my case, what I would say, they're mostly rural, right? That's a big issue. In rural towns, access and so on and so forth is complicated because there's not enough doctors, so on and so forth. Let me show you, what was it? There was a good one here. Pediatric. Oh, this one. This is hypertension, which can lead to all kinds of diseases of the heart. And in this one, look at the rates among the black population. 41 out of 10,000, while for Hispanic is 7. So look at that's an impressive difference. This is a disparity. This is one of the best examples that you can find of what a disparity. And it's not, it's not all over the United States. It's just in Illinois. So this number is scary. I'm always amazed of these numbers. So again, that's an example of a racial or regional. And of course, there are others as well, like homelessness and others that they have a huge impact on people's life. So this is the kind of metaphor that we have used to talk about our research. And the idea is this. Imagine that, let's forget that we're in healthcare. Let's suppose that we're firefighters. And you receive a phone call from a house. There is a neighbor that says, hey, this house is on fire. You go, you stop the fire. The house is okay, maybe just one room got a little bit singed. You go back to your, headquarters. 2-3 days later, another fire. Same house. You go there, you take care of the fire, and so on and so forth. Same thing happens. Over and over and over again. Would you be frustrated by that? If you go to the same house, to the same fire, and the house is getting worse and worse in each case, and you're a firefighter. Your job is to make sure that this doesn't happen. Well, in healthcare, something similar happens. We have patients that come over and over and over again to the same services, like the ER, the emergency department, just because there's no other options for them. And I cannot show you the data because it's we're working on it still. But we have patients that in 1 year, they've been on the ER 100 times. Imagine that, 100 times in the ER. Every 3 days, they're back in the ER. It's a house on fire, and we just cannot stop it, right? Or at least in the ER, they are unable to stop it. So anyway, So what we have learned, and this is, it's been around for a while, not only in our research, but in many, many other areas, we've find out that really the reality is that we need to address the social determinants of health, which probably you have talked a little bit about this in class, where the idea that we are not completely independent, of everything in terms of our health. Everything has an impact on our health. Just to show you some examples of things that we have worked on. There's a beautiful example that Dr. Smith told me about, and she was able to get some medication for free for diabetes control. And she was giving this medication to homeless people. So what happens when you give someone the right medication for diabetes? You would expect that all the health outcomes of diabetes, like blood sugar levels, all that stuff, would go down, right? Turns out that it wasn't working. So she was like, why? So anyway, she started asking questions, and turns out that these homeless individuals, they would take the pill, and then they would go to a church or any other place to have breakfast. Well, the breakfast available there were donuts and orange juice, which are absolutely horrible if you have diabetes. So, doesn't help, right? Just, that's a social determinant of health. What food do you get? The other example that I've seen in other research is that people that have certain microbial infections, and they do not get better, even though they have the right medication. Well, the problem is that the water is contaminated. So they are drinking contaminated water to take a pill that is required to take care of that, all those bugs, or all that bacteria inside them. So that doesn't work too well. Another thing that we found in our own research, and what we've done, and this is a great example. There's a lot of people out there, and here, not too far away from here, 10 blocks out from here, who are sick. They are willing to go to the doctor, but there's no one to take them. They just don't have anybody to take them. And you and I might think, we'll get an Uber. Well, they don't know what Uber is. Well, why don't you just get a taxi? That's a huge amount of money for them to pay for taxis. Well, there has to be a neighbor. Well, it's not that easy to get a neighbor that work full time, and so on and so forth. Well, you can take the bus. If you are at a certain age or with certain limitations, getting a bus is very hard. So as simple as offering people the ability to take them there. That's some of the projects that we're working on is basically that. Just, hey, you need to go to the hospital, you need to go to this doctor, we'll take you. Because if not, what happens? Well, I have an appointment, I don't go because I don't have a way to get there. I get worse, and then what happens? You need to call an ambulance and take you to the hospital, to ER, to the emergency department. And that's not really good for anybody. So anyway, we always go back to this idea that we just don't, in our research, we don't try just to think in terms of health, in terms of a medical intervention, but also in the context out there. And there's many examples of that. Let me just talk to you very quickly about something that I do in this. By the way, this slide was prepared by one of my students, and because he was in this project. I work, one of the projects that I'm working on with SIU Med and other universities is this idea that we put together interdisciplinary teams, again, that word again, and that's what it means. We put together medical students, pharmacy students, social work students, and even business students in these teams, and their job is to identify a member of the community that is falling into this problem that is getting sicker and sicker, going more and more to the ER or getting procedures that are not necessarily for the best for all of them, and how to get them out of that. And as I mentioned, might be as simple as making a plan with them. You know what? These are 10 times that you need to go to the doctor. We'll take you. And our students will drive them to those places. Simple things that we do, for example, the pharmacy students, they will get talk to the patients, and they will say, okay, give me all your medications. And I kid you not, will be bags, a bag of medications. Why? Because they've been going to the ER for 20 times in 2 months. And each time that they go, they do not mention that they went before there, or they feeling too sick to mention anything. So they end up with more medication than required. And medication that might be like, this one goes against this one, is like taking, it's not helpful for you. So simple things. We are not changing medical research. We're not giving the most advanced new drug. It's just basically coordination, companionship, if you want to call it that way, and any type of education. For example, many years ago, in one of the first times that we did this project, my students, the one from the business school, they just went to the supermarket with one of the patients because he had diabetes, and he had no idea what to buy. Like say, well, I just buy this food, and say, no, let me tell you how to buy stuff and where you can find cheap food, so on and so forth. So anyway, I've been working on this, and this is where I learn a lot. I have done work with Dr. Smith, and it's been presented in conferences and so on and so forth, in many conferences, and the results are, again, very positive. We can make people change their lives without, again, you don't need major changes. You just need to be there. So what are my responsibilities in this project? Recruit UI students. If you're interested, let me know. I'm always looking for new people for these projects. You do not need to have a medical degree. You don't need to be interested in, taking care of a patient's bandages, anything like that. There's nothing of that nature. Most of the time, my business students, they just coordinate, they just offer leadership, and they do things that are a little bit, all over the place. Every year is different. So anyway, that's something that I do if you're interested. Other thing that I do for them, data gathering. I'll talk more about that, but it's complicated to get data about patients. And oh my gosh, it takes forever. I try to do fundraising, not today, so I won't ask you for money or anything like that. And data analysis, that's pretty much my most important aspect for me, that I help them with data analysis, which is kind of complicated. It might seem simple, but healthcare data can be complex. And if you don't do the right techniques, you can end up saying things that are not completely true. Any questions so far? Everything okay? We're good? All right.
I'd like to share a quick
Sure.
observation about potential interrelations of some of those variables.
Right.
Last Saturday, we had a family get-together, and my niece said, Uncle Dave, I have to leave early because my church is part of a group. We go down and provide a meal to the homeless in downtown
Sure.
St. Louis. I said, oh, okay. Tell me about that. And so she was talking about, what she did, and she tossed salads and whatever. And they served 120 homeless people.
Mm-hmm.
And then she happened to mention that many of them have mental problems.
Oh, yeah. Mm-hmm.
So homelessness is not a simple notion.
Right.
It overlaps the mental health
Sure.
issues.
Sure.
So I made a mental note as I revised
Mhm.
this course for next semester.
Yeah.
To put much more emphasis on homelessness and mental health.
Right.
And then I'll be
Yeah. Mm-hmm. Yeah, absolutely true. If you look at, again, I cannot show you the data for the patients, but yeah, it's always a combination. It's not just diabetes. It's not just any of this. It's a combination. And And when you see race, it's not only race, right? It's race, education, income, the environment that they live, so on and so forth. So yeah, it's very complex data. And that's why for me it's a lot of work to get this data together. It takes me a long time. And how to analyze the data, I'm more used to experimental research, and this is very different, but very, very fascinating. So anyway, so this project as well as other have changed my way of thinking. The data that is available out there, most of it is not really about vulnerable populations, not really. It's all over the place. So you need to do a concerted effort to get that data. It's not as easy as others. Have you talked about ICD-10 or not here? Maybe in the technical courses. Basically, the data that you're going to get is very simplistic. If you use the traditional data systems available. ICD-10 is basically each provider writes down this number, this code, and this code turns into okay, so this person was here for dialysis, for example. And it's just the code, but you just get the code. You don't get more than that. You get reimbursement data if you are lucky, and stuff like that. But social determinants of health, you get nothing. There's no data available easily for each patient. All these other things, ICD-10 and all of that, easy. I teach marketing, I teach particularly healthcare marketing, and I feel kind of awful some days, because what I teach in that healthcare marketing course and what people are doing out there in the marketplace in healthcare marketing, it's for privileged people. And that's okay, there's markets for everything. But in some ways it can exacerbate disparities, and I'm going to show you an example. The other thing that I learned, in general, students that are in my classes, we are just very, very fortunate. There's a lot of suffering out there. There's a lot of people that, and really, they're not far away from here. And life is difficult for them. And it's been eye-opening, and I advocate in many places, from federal agencies that I'm working with to local agencies that I try to help. An example of exacerbating disparities. This is a great example of exacerbating disparities, probably. The University of Michigan, which is a wonderful university, one of the best medical schools and medical programs in the world. This is a world-class organization. They got in trouble because they created this program where basically if you pay, I believe that last time I saw it, and was some time ago, like $2,000, you can skip the line and be the first to be treated. And you have a doctor that takes care of you, like a concierge system, right? Where a doctor is always personalized medicine at the highest level. And what people were saying is that, wait a minute, you're saying that if somebody pays $2,000, they go ahead of everybody else? So what about the people that cannot pay those $2,000? Does it mean that because they've been skipped, it's going to take even longer for them to take care, to get care from you? And again, it was a major fracas and a major issue. I'm amazed that they still have it because of how bad it was for a while, the criticism. And this is the kind of stuff that you need to think about, right, when you're putting this together. It's wonderful that you create this. It brings more money, obviously, to the to this healthcare organization, money that you can use in protecting vulnerable populations. Yet, at the same time, it's like, am I doing this for the right reasons and for the right results? So anyway, I always talk in my classes about the traditional marketing, and almost always say, however, this, because there's a lot of things that we do in business that is mostly for profit, and we have to balance better or desire for profit with helping populations that they might not have the resources to be profitable for us. So anyway, I have a challenge for you. I hope that, it's up to you, you take it seriously or not. But things that I think will be helpful for our society. a simple question: is there anything you can do to help in the position you're going to have in the future? I don't know. I don't know exactly where you're going to be working, but these are things that I would like someone to work on. How to develop safe, HIPAA compliant. You know what HIPAA is? Have you talked about HIPAA? HIPAA compliant systems that are shareable, scalable, and easy to use by medical personnel as well as other professionals. Right now, sharing data is an absolute nightmare right now. When we have interdisciplinary groups, because doctors can see this much information, pharmacists can see this much information, I can see certain amount of information. And to get all that data together, we need to get I don't know how many permissions, which I get it. I totally understand why we need to go through all of that for all kinds of reasons. But it's so hard to share data. And is there a way to do it in a safe manner? Right now, we do a combination of secure email, Slack, Google Classrooms, but a lot of that information we are so careful about, up to a point that sometimes I have to go to an office and get a drive, a small, like a stick, a memory stick, because no, I don't want to give it to you via email, anything like that. So you're like, oh my gosh, so I have to go there, get it, put it in my computer and so on. So is there a way to do that? These two are interrelated. How to include social determinants of health on medical records, in health records. At the same time, how to reduce reporting burdens. And there's two very good articles about it. One is a research paper by Rachel Gold, and it's about social determinants of health and how to include them in EHR tools, electronic health records. And it's a good paper, but can you imagine asking people, nurses, physicians, and others, to write down a lot of information about each patient? The problem is that we end up with something like this. This is an article in The New Yorker, which I highly recommend, by Atul Gawande. If you are not familiar with his work, Atul Gawande, well, I can write down. But anyway, if you need more information about him, he writes about medicine. He's a wonderful, wonderful writer. He's not a typical researcher. He's more of a popular writer. And he had a recent article in New Yorker about why doctors hate computers so much. And it's basically because they spend so much time inputting data instead of treating the patient. And doctors are burning out. They are tired of doing this, and it's a problem right now. So on the one hand, we want to add more data into health records. On the other hand, we're saying, oh no, we're tired of this. We cannot do this anymore as right now. And particularly, Dr. Gawande's article is about the implementation of EPIC. Have you heard about EPIC, the system? It's one of the systems used in most hospitals, and it's an absolute nightmare to make it work in the first year. They talk about losses of $1 billion in the first year of implementation because it's so hard to make it work. And say, now we spend all the time working with this system and we're not talking to our patients. So anyway, that's one of the biggest challenges that I can see in your field, which is I want more data, more secure data that I can share with everybody. But I don't want that to be a burden for doctors out there. And I don't know how to do it. I really don't. There might be a creative way to do it, but we are out there. So anyway, sorry that I just went along. Any question that you may have, anything that you want to talk about before I move on to my next meeting? Unfortunately, as an administrator, I spend all my time in meetings. Anything?
Questions?
No? All good? Okay. If you have any questions in the camera, just send me an email. Okay, I'll send you. So that's me. By the way, I'm in Twitter. In Twitter, We like to, the kind of Twitter that I like to use is the academic Twitter. I basically follow people in healthcare, marketing, advertising, and other areas. So that's basically what I do. I don't talk about my family or the kind of sandwich I ate today. It's basically that. So again, if you have a Twitter account and you want to follow someone related to healthcare and other things, please do so. I try to stay away from politics and stuff like that for many reasons. Every now and then I just get too angry and write about something, but most of the time it's about healthcare. The other thing that you can do, this is my email address, jvill and the number 2 here at the UIS. Anytime that you want to talk about it, if you're interested in the hotspotting project, we start hotspotting teams once a year. And usually I need to have names during summer. So again, if you're interested and even just know more about it, please let me know. And that project is, I love helping in that project. Sometimes students get a lot out of it. Sometimes after 2 weeks they say, not for me. And that's fine because, you know, all of us were different people. We're able to serve in different ways. But at least it will help you understand what we see there. And I don't see it, by the way. I'm not the one going to talk to patients. I've never seen a patient in my life in these programs. Everything that I do is the data. Basically, I know them by Excel. And I don't have names, ever. I don't even know names. I just have codes, and I see their medical history. And in that medical history, I see so much pain. Imagine if I met them. I'd be like even angrier or more worried about this stuff. But people like you, students, meet patients, do wonderful work for them. All right, so again, thank you very much. Let me know if there's anything I can do to help you, all right? Thank you.
Well, thank you, Dr.